Good morning and welcome, everyone. We're delighted to have you once again for the Grand Round series from the Center for Spirituality and Health. If you have not signed in already, I would ask you to please do that. Make sure you sign in on your way out. It's very important that we get an evaluation form for you, which you may have picked up on your way in, but if you didn't, it's on the table right outside the door. And now I'm going to turn it over to the Director for the Center for Spirituality and Health, Dr. Deborah Marin, who will introduce our speaker today.
Good morning, everybody. It is really my pleasure to introduce Mr. John Rhee. John and I have known each other now for a few years, and I'll give you a CV, which I don't have in front of me, but I remember the highlights. So John grew up in New Jersey, and when he was still in high school, he became an accomplished musician who won awards in New Jersey. He went on to Cornell, where he graduated with honors, and he has now come to Mount Sinai Medical School. And in his 2 years and 5 months since he's been here, he's already published. He's already won national awards. He's already earned his master's in public health while being a medical student. Very unusual for somebody so junior to do that without taking time off. And John came to me. He has an interest in spirituality, and we were talking about ways that perhaps we could improve patient care at Mount Sinai. And in concert with Dr. Vin Nguyen, who is one of our senior hospitals at Mount Sinai, we identified the opportunity for figuring ways to break down the barriers to get folks to be seen by chaplains more at Mount Sinai. So while John was a full-time medical student, he did this project. He did qualitative research. We'll hear about it. And John will be a star. He already is a star. And I know that hopefully a few years from now, I'll bring him back here when he's a full professor at the age of 32, probably, in some department, the medicine and pediatrics, and we'll hear more about his work. So I'm really absolutely so delighted to introduce John to the Grand Rounds. Thank you.
Thank you so much for being here today. I'm John. I'm a third-year medical student. And I'm going to be talking today about a quality improvement project that we worked on last year to try to assess and address barriers to receiving spiritual care at Mount Sinai. So kind of just a very brief background on why this project interested me. For me, faith is very important to me, and it's been a very important part of my life, and it's been the reason why I applied and came to medical school. And personally, I also felt while I was in medical school during my first 2 years at Sinai, the spiritual education curriculum, it wasn't very emphasized, or there wasn't much of it, I guess. So I wanted to do something to try to address barriers to potentially receiving spiritual care here at Sinai, and then also to kind of also be able to basically help patients be able to receive that care. So I approached Dr. Marin, and she was a great mentor, and Dr. Nguyen, and we decided to come up with this project in order to try to help address some of those barriers at Sinai. So today I'll be talking about this QI project that we did, and the project has morphed a little bit over the time in which we were conducting it, but I'll also let you know as we go through it. So I'm a student and have no disclosures. And the funding was from the Advancing Clinical Excellence in Medicine grant program, which is run through the Division of Internal Medicine. So I'll start with the background on the topic of spiritual care in general, as well as at Mount Sinai. And then I'll go into the methods and the framework for the QI project, then the results, and then the discussion, of course, on the things that we found. And as in any research, the next steps that we expect to do from this project. So starting with a little bit of a background on religion and spirituality. So there's been a recent increase in interest in spirituality, as I'm sure many of you are already aware, since you are here at the Grand Rounds, playing an important role in patient care in the hospital, and accordingly an increase in research in spirituality. This is because studies clearly show that patients want discussions about religion and spirituality with their healthcare providers. Furthermore, discussing this religion and spirituality has been shown to result in positive outcomes, such as decreased psychological distress and better psychological health for patients. And this isn't just something that is important to people who feel spirituality is important, such as people in this room. But JCO also clearly states that healthcare professionals should receive training in this area because it leads to positive health outcomes for patients. And JCO is a Joint Commission on Accreditation, as I'm sure many of you are aware. Furthermore, this is of interest especially today with changes in the healthcare landscape. There's greater focus on patient satisfaction and reimbursement at the hospital level. This is, of course, a secondary benefit because the primary benefit is always the benefit of the patient and meeting the patient's needs. But it is also important to note that although 41% of inpatients wanted to discuss religion and spirituality, it is estimated that less than half of those patients who want to discuss it have those needs met. And in fact, patients who had discussions about religion and spirituality were more likely to rate their care at the highest level on 4 different measures of patient satisfaction, whether or not they wanted to have such a discussion. And my mentor, Dr. Marin, also published a paper showing that chaplain visits were associated with positive patient satisfaction. This seems like it would make sense, but it's also important to quantify the things that we know are true so that we could kind of advocate for more of this kind of care. And patients were more likely to endorse staff met emotion and spiritual needs, as well as stated that they were more likely to recommend that hospital to others. One of the key studies in the chaplain literature is this longitudinal study in New York, the New York Chaplaincy study. And this study showed that most referrals came from nurses and patients, and that physicians and social workers are far less likely to refer patients to chaplains. One of the arguments that I personally have heard is that people don't know how to meet patients' spiritual needs, and therefore they don't feel comfortable addressing the needs. However, there are studies like the second one at Albert Einstein, which was done recently, where they did an OSCE, which is kind of like a standardized patient test for medical students, on spirituality on third-year medical students. And they showed that most people can make, if not all, can make a referral without robust training in addressing spiritual beliefs, although having some knowledge is, of course, preferred. And it's important to note this fact, that most say that the barrier to addressing spiritual needs is that they have not been trained. Well, you can still make a referral even if you haven't been trained in spiritual care. And we'll be kind of coming back to this concept as we have done some qualitative work with providers as well in this QI project. So what can we actually do, and what has been done in order to try to fix these barriers to receiving spiritual care? So here I wanted to move on a little bit to speak a little bit more about what research has been done in terms of improving referrals for patients. So La Rocca Pitts has an excellent paper, which you should all read, where he speaks about different models used for finding patients. And the paper outlines kind of 3 different models, the first being case finding, where chaplains initiate rounds, visiting all new patients, all new admissions, or rounding at nursing stations. So this is one model of finding patients. The second model is referrals, where chaplains receive referrals from third parties. These include daily rounds, attending interdisciplinary rounds. And then the third is a standard response to a predetermined set of criteria. So for example, for all patients that have a certain code status, or for all patients that are end of life, or all patients that are going through or set aside for trauma. For example, chaplains will visit all of those subset of patients. So these are kind of the different models that are being used. So this gives us kind of a model moving into the next few slides, where we can think about various places for potential intervention. And I will come back to this in the discussion, but I wanted to introduce it to you before going through the project, so that you can keep it in mind while we talk about the QI project, and we can discuss it again in the discussion. So I would say at Sinai we mostly base our model on the second, through the referrals process, and this is why we decided to focus on this level of finding patients. Now that we have a better idea of the need of chaplain referrals, the importance of addressing patients' spiritual needs, and a general overview of different models of referrals and how we can do it even with minimal training, all the more is, of course, always needed. Let's move on to how we do it at Sinai. So at the time in which we wrote this grant, Mount Sinai Hospital scored fairly poorly on Press-Ganey reports, which is what facilitated this study and the need for such a study. We also identified that Mount Sinai Hospital lacks a standardized process to address patients' spiritual needs, which we felt could be improved with a quality improvement project. We chose to work with 10 Center, 10 West initially, but also incorporated 9 West, which are floors at Sinai. And we chose these floors specifically because patients stayed a bit longer and were fairly sick, and therefore more time for chaplains to intervene. And we felt it might be better on these floors with a set system for us to find a specific place to intervene. Now, even though percentage-wise it seemed like we did poorly, I just wanted to put this slide up to note that things are not abysmal in terms of the percentage of patients whose spiritual needs are met. We have a meeting greater than 70%, but of course for a patient who is very sick and wants their needs met at such an important time in their lives, and all of you know that sickness is a time of deep existential crisis and suffering for patients. And so there's always places to improve. And so this was also kind of the driver behind why we wanted to try to find an intervention for the patients. And so finally we come to the project. So our aim was to analyze and assess barriers to addressing patients' spiritual needs at Mount Sinai Hospital and to develop a quality improvement intervention to improve provision of spiritual care in Mount Sinai Hospital's medical inpatient units. So we took a two-pronged approach. First, we did qualitative interviews with both patients and providers, and we wanted to get better insight from both parties as to what they thought were barriers to spiritual care being received and given at Sinai. And then we used those qualitative interviews to develop a quantitative survey in order to reach more healthcare providers to get a wider view of whether the interviews were reflective of the greater population of healthcare providers at Mount Sinai. And this survey was conducted from December 2014 to March 2015, and we did the qualitative interviews from August 2014 to December 2014. So we ended up interviewing 12 patients, and the breakdown of providers is above. Oh, actually, those breakdown of providers is the quantitative. I apologize, but I'll also go into the qualitative. So this is the response rate of the quantitative surveys, the second of the two-part approach. And so the response rate was very good with social workers, 100%. The nurses, it was a little bit more difficult to get responses because a lot of people were on different shifts and there are a lot of nurses, and so some people are on night shifts, some people are on day shifts. And so we had a poor response rate. We try to facilitate answering the surveys by also providing physical copies on the floor. And we also send out multiple emails with the help of Dr. Nguyen, who is my mentor for the project, and who's a hospitalist that's working on the floors. And he was also crucial in getting me connected with everyone on the floors. So here, I'm just going to briefly summarize for you just a few of the qualitative responses from patients and providers. I chose the questions and answers that seemed most interesting to present, although there were much more questions, many more questions. And so the first question was, what patients thought chaplains did? So overall, there was poor knowledge. Patients felt that they were mostly religion-based, which is important to know, especially if a person feels not connected to a specific religion but considers themselves more spiritual. And so these are some quotes that I took from the interviews with patients. Patients would say they are reverends, preachers, ministers, so they're indicating kind of a specific religion or their perception of what a chaplain is. Some had never heard of the term chaplain before. Some said that one said that it was prayer for people, and they are leaders of religious institutions. And another patient said they help us in prayer. In the hospital, I'm not too clear about it. I don't have the details. They pray and talk to you. When patients were asked what spiritual services were provided, they also had a fairly poor knowledge of what services were available. So it's also important to note that there were some that had never heard of what services were available. It's also important to note that when patients are coming into the hospital, there are a lot of other issues, right? That they're very sick. When they're coming in, they might not be in the right state of mind, and so they could have received the information but not have been able to process it. And so it's keeping in mind all of these different things as well when we're talking about these qualitative interviews. So one patient said that, I know they have ministers and people from different faiths that come around to ask you how you're feeling and prayer if you need. Another patient said, I have never heard, I just know that they had the service because someone I was rooming with had someone visit from the chapel, and patient A said, I don't know. But even if a patient says, I don't know, even if they did receive the information upon admission, it's important to know that there might be other places for intervention if the patient wasn't able to absorb it at the time of admission, for example. When asked what services should be provided, patients that were religious suggested specific models and methods they were aware of, or mentioned that they did not feel needed in terms of spiritual support. So patient 1 said prayer and Bible track should be offered. I think they should be able to, when possible, get in touch with the patient's family. Another patient said, I think praying and reading the Bible would be nice, at least for me. And there was a patient also who said, pertaining to me, the answers would be no, because I'm not very spiritual. So I tried also to pick different representative samples of the interviews as well. And the general feeling of patients were that staff did not meet spiritual needs, but also they were very forgiving, stating that many felt that they understand why staff wouldn't ask or meet their needs. So patient 2 said, I haven't spoken about anything spiritual with the healthcare team other than the chaplain, or I have no spiritual needs to be provided. Patient 7 said, if they asked me, I wouldn't be offended, but no one ever has, and I don't expect them to. It's a tough thing, because people believe in such different things and in different ways. And patient 10 said, no, not really. I mean spiritual needs, as in the staff here, like the nurses and stuff, not all of them. Some of them are religious, it depends. Some of them aren't. I guess it depends on the conversations we have. I really don't know, no discussion about spiritual needs. So now let's switch briefly to providers. So we also interviewed providers to ask them kind of similar questions. So the questions were modeled very similarly to the patients to see kind of the counterpart of what the providers thought, knew, and perceived. So in terms of asking if providers knew how to contact chaplains, the general consensus was that there were many different ways. Some did not know how, and others mentioned a variety of different ways. So one of the social workers mentioned, I know that there's a way to order the consult on Epic, but I'm not sure how to do it. I don't know if I even have the permissions to do it. I think maybe just the nurses do. Another social worker said on 10 West interdisciplinary rounds, we have a chaplain that comes in person on Tuesdays. An RN said, I ask for the extension code and then for the spiritual consult in Epic. The chaplain gets the order and they come see the patient. Another nurse said through the spiritual care department by calling and following the prompts. 2 PAs said there should be a better way because you're not sure if you're getting the right person. You're leaving the message for it and it's confusing who you're calling if you get the right chaplain or person. Another BA said because sometimes they're not here, especially on weekends, it's hard to get a chaplain on a weekend. And a nurse said usually at admission we ask that question. Providers, though, had a better understanding of what chaplains do and what kind of services they could provide. Social workers said, I think of them as counselors for patients with a religious approach. A nurse said when patients are very sick, they get down and depressed, and a conversation with that chaplain would help them feel better in a positive way. And another social worker said kind of they have the ability to tend to patients' well-being, versus a social worker, though we want to take the time to sit with the patient and discuss how they feel, a lot of times you just don't have the time to do that. And although everyone said that it was easy to place chaplain referrals, we wondered why providers might not be placing these referrals. And one person recommended during the interview that MSIII listing and streamlining of the process might be something that we can consider. And so I'll kind of go into that. We also asked how the providers address patients' spiritual needs, and many felt that they did not feel comfortable, or that if they did come up, they would ask if the patient would like to see the chaplain. They more addressed it if it came up in conversation rather than pursuing the conversation as a standardized part of their care. This was the, yeah. So here we have the quantitative data. So as I mentioned before, the quantitative data questions were derived from the qualitative data. So after the interviews, we kind of went through the themes in the qualitative interviews, and we developed a quantitative survey in order so that we can in a wider audience of what people actually felt, and if the qualitative interviews were representative of how other healthcare providers felt. And as I mentioned before, we focused on the questions where we felt we wanted further clarification as well. And what was interesting overall was that most of the referrals that people reported were coming through Epic. So this is something we found interesting since in the chaplain literature, there is very little information on the means of using technology and spiritual care referrals. Furthermore, we found that the top 2 answers for how people wanted to request a chaplain were electronic means, so using technology. They requested Epic and MSIII. And once again, this is interesting, but also makes sense because our healthcare system is moving towards a model in which we are using electronic health records, and I will also argue in the discussion as well that perhaps the chaplaincy world should be or could be moving in that direction as well. And the following are summaries of a breakdown to further quantitate how healthcare providers felt about different aspects of meeting patients' spiritual needs. Most found it easy to request a chaplain, which is reflective of the qualitative answers, and most felt comfortable or neutral addressing patients' spiritual needs. Although once again, patients felt that they weren't speaking with their healthcare providers about spiritual issues, but still, nevertheless, indicated they felt comfortable or neutral. And most felt that spirituality and religion was important to them, although this is in line with the literature as most of the respondents were nurses, and nurses tend to be more religious given the vocational aspect of nursing and the history of the nursing profession. The most common way that providers address patients' spiritual needs was by requesting a chaplain, although a small percentage did actually pray with the patient or provided spiritual counseling themselves, which I also found very interesting. And the average number of times, and this is important to note, that over the past year, so 12 months, that a chaplain was requested was between 2 to 5 times by the people we send out the survey to, which, thinking of the number of patients that come through the hospital, is a very small amount. And so it seems like most people in general request chaplains very few times, and there are a couple superstars that request chaplains for almost all the patients that they see. And so if reflective of the qualitative interviews, the numbers were likely closer to 2 than 5, at least when I was interviewing healthcare providers. So here is just an overall summary of the results broken down by profession. And we're going to talk a little bit more about this in the discussion, so don't be overwhelmed by the chart. But here, I just wanted to point out that nurses and social workers felt comfortable addressing spiritual needs compared to physicians. Another highlight is nurses more often felt personal spiritual beliefs were important compared to social workers or physicians. Nurses were the ones who were most frequently using Epic, while physicians most frequently used interdisciplinary rounds, and social workers used seeing chaplains and requesting them on the unit. And physicians and nurses felt that MSIII and Epic, as well as email for physicians, would help request chaplains, and this was the preferred methods, which are all different uses of technology. From this information, with a higher desire to use technology to request chaplains, we developed a spiritual care and education area on MSIII for easier referral requests. So a brief explanation of what MSIII is in case you don't know. It's an online system where a person can put in the schedules of persons who are on call in the hospital. And so for the date listed, the person covering for the date and location can be obtained. And a text system through MSIII links to pagers can send messages to request referrals. And so as a medical student, I can vouch that MSIII is used very frequently for referrals on the floors. In fact, I would say a majority of referrals to subspecialties are requested through MSIII. And furthermore, Epic referral capabilities are already in place, although at the time it was only available for nurses. But now social workers also have the ability to do that. So you can see here that there's a spiritual care and education tab in MSIII now. And here we see a list of chaplains on call when one clicks on the spiritual care and education section of MSIII. And you can see the chaplains that are covering, as well as their contact information and all of the different floors. And so it makes it very easy, depending on the day. So you could search by day. So here you can see that I just did June 2015, June 23rd. Because that was a day that I just chose for the presentation, but really you can put in any day and you can kind of find the people on the floor to contact for your specific for chaplain requests. In order to see how many people were responding, we did another short survey sent mostly to nurses, as they are usually the ones who are requesting chaplains, as you saw from the previous data. And although I know that this isn't necessarily the best way to get this data, and I'll tell you a little bit more in the discussion section as well about this, but it showed that preliminarily, at least at this point in time, 19% were aware and using MSIII, at least the people who responded. And we still have much more education to do because a lot of people are still not aware that that there is this tab on MSIII, but at least it's starting to be picked up by different providers. And so we come to discuss some of our results. So large systematic reviews showed physicians infrequently discussing religion and spirituality. Physicians are shown to infrequently discuss religion and spirituality, and common barriers include lack of time and lack of training. And so this was also reflected in our current study because physicians felt the least comfortable with addressing patients' spiritual needs. And this is also reflected in the greater chaplaincy literature as well, in the literature with regards to religion and spirituality and addressing patients' needs in the hospital. And as mentioned in the beginning, most referrals come from nurses, as mentioned in the New York Chaplaincy study in the introduction. And our results are slightly more varied in the nurses column, perhaps due to the sample size and a potentially non-distributive sample, because this was, obviously, it was a convenient sample. But still, there's a high percentage of nurses that do the referrals. And so the literature also shows that nurses request chaplains at the highest numbers. And the reasons for referrals include seeing that a patient was feeling badly or in pain, if the disease was with poor prognosis, or there were treatment issues, and end-of-life issues. And so those are kind of the different reasons in which people did end up requesting chaplains to see patients. And so I did a review of different techniques out there to improve referrals to chaplains. So there are methods of spiritual screening, formalized tools that can be used on admission that have increased referrals to chaplains. So Piotrowski developed and tested a formalized tool for screening patients at admission or through the hospital visit, and he talks about that a little bit in his article called Advocating and Educating for Spiritual Screening Assessment and Referrals to Chaplains. Blanchard in 2012 screened in the oncology inpatient unit using a 2-question screening tool. I thought that this was interesting because in medicine we often use kind of these 2-question, like a PHQ-2 for depression for screening, and so it's interesting to see a tool developed in which somebody's using this kind of model of using a 2-question screening tool upon admissions to try to focus on which patients might need this the most. And so it was a pretty small project though. 6 nurses made referrals for 14 patients, so it's more of a pilot project. But 4 of them, about 26%, were 4 of the patients were at risk for spiritual distress and were assessed by chaplains. So 26%, I mean, it's not the highest percentage, but it's still, I think, a very interesting model to think about in terms of finding which patients might be at the highest need, since, as many of you know as chaplains as well, that it's hard to see every single patient in the hospital as well because there are so many patients, a lot of overturn, and so the idea of targeting which patients might be most at need is through a screening tool is, I think, very interesting. And Gomez-Castilla developed a project to try to increase outpatient assessments via chaplain co-visits. So the chaplain would, for a short period of time during the medical visit, actually co-visit with the doctor, which I thought was also an interesting model to use in the outpatient setting, which increased spiritual assessment from 25.5% to 50% increase in spiritual assessment for patients. And so, if you remember, I asked you to keep that model in mind in the beginning of LaRocca Pitts and how there are different models for getting referrals for patients. And so I think this provides a lot of promise because the new electronic health record age allows for chaplains to potentially seek patients through electronic means. So for example, procedure-specific protocols can capitalize on EM, electronic health records, or EHRs. For example, for pre-op patients, so patients that are getting evaluated to go into surgery, a chaplain, for example, can acquire a daily list of all surgical patients that are going into surgery that day. And this is just one example, but the argument is that a chaplain referral that is added on after the fact is not really an integral part of the clinical pathway, right? So if a patient comes in and it's just kind of added on, it's not necessarily, that's not how it's viewed. And the goal is to integrate chaplaincy referrals, and EHRs can facilitate that automatic generation of all protocol-based referrals. As mentioned before, if it's all patients who are trauma code or all patients who are going into surgery that day, or kind of standardized ways where you can pull that from an electronic health record in order to be able to specifically target patients that might most need it. And using EHRs can facilitate this process by looking up patients individually or through order sets, as mentioned in the surgical order. So you can see the patients in that set. Or automatic referrals for orders made, for example, all patients on DNRs. So if all patients that are on DNRs, one of the arguments that this article makes is that then you could kind of generate that list of patients who have been placed on DNRs, and those are the patients that chaplains can go see. And briefly returning to discussing the qualitative data, because I'm sure you're also wondering, so what happens to the qualitative data, other than using it for the survey? But mostly qualitative data for providers was used to develop the quantitative survey, as I mentioned. And as I kind of mentioned in the beginning, the project kind of morphed throughout the period of time in which we were conducting this project, because the purpose of the qualitative interviews was more to gain a better understanding of places in the streamline of chaplaincy referrals where we can make an intervention. And so we were thinking about whether we wanted to do the intervention more on the patient side or more on the provider side. After we gained the qualitative data, we saw that there was kind of a specific intervention location that was available in the provider side. And so we ended up deciding not to pursue the intervention in the patient side. But it was still, the interviews were still, I think, very interesting and can be used for future studies as well in terms of patient education. And a lot of those initiatives are already being done by the department here. And so that's why we also decided to more focus on the provider side. And so what did we do next? So we have we concentrate on, so we spoke a little bit about MIII, and we concentrated on one aspect of increasing chaplaincy referrals on MIII, but now we kind of have to evaluate whether there was an actual increase in referrals. And so one of the arguments is that if you create a system on MIII, it could be that the same people are doing the referrals, but they're just shifting to using MIII rather than calling. I would personally like to think that that wouldn't just be the phenomenon that's happening, because being a medical school student on the floor as well, to call is very cumbersome, and it's very difficult at least for healthcare providers who are like constantly doing things on the floor. And so I would like to think that this process would increase referrals. And although we were gathering data for this, I didn't actually have time to look specifically at the whole numbers for referrals before and after the intervention. But we also need to do more education as well. So for example, we incorporated a slide into resident orientation for medicine residents. So it's just a slide to introduce them to the fact that this process now does exist on MIII. And so at least it'll be introduced to people who start coming in for residency here. And the other thing that I think it's important to do is we hope to better educate and incorporate social workers as well. So a large part of this presentation, we spoke a lot about nurses and physicians, as well as a large part of the discussion as well. But social workers are oftentimes speaking with patients about very deeply personal issues. And so targeting and working with social workers and increasing referrals from social workers, I think, is also an area where we can look more into at a deeper level. So thank you very much. I just wanted to thank Dr. Nguyen, my project mentor. So he was my project mentor for the project. I need a person in the internal medicine department to help me with the grant and to actually implement the project. So I wanted to thank him for his connections and helping me connect with all the people on the floor. Of course, Dr. Marin, who first agreed to help me with this project when I approached her, and also the idea itself. And Rabbi Goldstein and Dr. Sharma, who provided invaluable insight and encouragement. And of course, Dr. Markov and Shaw, who advised on the grant itself. And all the nurses, physicians, all the staff who partook in the survey, as well as the patients. So now I'm available to answer any questions that you may have, and thank you very much.
Hi, thank you so much, Dr. Rhee. I think over the past year or two, I've heard some of the responses from your research, kind of intermittently, but it was great to hear it all in this format, so thank you for the work. This is kind of getting off the subject, but I'm so curious about this. Did you have any exposure to or any research moving towards technology in the sense of any videography that are done in spiritual care? I know we have an in-house television channel, believe it or not. It's got about 3 hours on it. It's not very well organized, but I know our healthcare chaplaincy network and places like that have really robust programs that have chaplain visits and educational things. And I didn't know if that had, if you did any kind of, so anything about how that was an impact.
Yeah, so for some of these questions, I'm going to ask Dr. Marin for help since she's really the expert in the field. But for me, at least, when I was doing the literature review for the grant itself and for the presentation as well, the literature on any means of technological use, like whether it's video or electronic health records, was very, very limited. In fact, there was almost no articles, like maybe 1 or 2 when I looked up electronic health records and referrals. Maybe not 1 or 2, but it was very few. And in fact, outside of that, using other kind of techniques, there were very, very few. But I'm not sure specifically on videos. I didn't come across any, but.
That's a good question, Maggie. I think I'm actually going to ask 2 folks to answer this question before I answer it, actually, because David Fleener's here, and he developed at Healthcare Chaplaincy Network the ability to speak with chaplains over the phone through their website. So I think, David, you could talk about that initially.
So our colleagues at the Healthcare Chaplaincy Network have developed a couple of technological innovations for chaplaincy. They're untested and unmeasured at present, but in the process of attempting to seek partners for pilot projects. But the 2 that come to mind is there is a Healthcare Chaplaincy Network TV, which is 10 roughly 30-minute programs, pre-recorded programs that speak directly to patients and caregivers about various spiritual care issues like grief and loss, what is spirituality, some spiritual practices. Interestingly and anecdotally, the most popular of those 10 videos is inspirational quotes from various religious and spiritual traditions. It's not so much the talking heads of the wise chaplains who are sharing their wisdom about grief and loss and that sort of thing. So again, that's anecdotal. The second and larger project that we worked on there had to do with what we were calling telechaplaincy, and it was the ability to interact with the chaplain via email, telephone, or webcam. And it turns out that people still like to talk on the telephone much more than they like to chat via webcam. And so there was some data about that, but none of it's published. So there are some forays into the use of technology. And the last thing I will say is that in the most recent edition of the Standards of Practice for Professional Chaplains, one new standard is the chaplain's use of technology. So I'm very mindful of that when we're talking about MSIII. I think what prompted that was probably our use of electronic medical records, but they left it broad as the use of technology, and I think that's certainly inclusive of the MION technology and other sources or forms of technology that would help people reach out to us.
And Dr. Nguyen, if you have an interest in technology and its role in medicine, I thought you could speak up to this as well.
Sure. So what we're finding with patients and forms of technology is that people do like to have access to the providers, and one of the things that is kind of being explored right now in the internal medicine world is having access to providers via webcam that's more kind of direct and kind of earlier. Again, this is from a provider standpoint also kind of untested, unproven as well, and it's still kind of being looked at. But I think the things that patients really do enjoy about the technology part is having kind of more faster, easier access to their providers.
Thanks. So, my opinion is great work. Published, for sure. I think that the issue here is what roles do chaplains play in the healthcare environment, and how should we get to patients? And I think that's, to me, the answer is through many roads. I really don't think there's one way to go. The reason I think working through the patient is probably not the best way to go, because patients don't know what chaplains do, and they're in distress. And in the hospital setting, patients don't say, excuse me, I want to see a psychiatrist. It's just not how it works. It's really the provider's responsibility to determine if there's a need, either on the chaplain side or the non-chaplain side. In terms of technology, what's very good about MION is now we can calculate how many people use MION, because when a chaplain gets an MION text, it says, would say Debbie.MION. So you can now put in your notes, and we have to make sure it's a drop-down, that MION. So we'll be able to quantify, actually, and develop reports based upon that. That's very important. The other issue is that screening. We have tried many ways at Mount Sinai to get screening going. And actually, in EPIC, there is a screening tool, 2 questions, for the nurses. And I've been following the answers that the nurses provide, and I don't think that particular screen works. In part, it's not being used, but I don't think it's very sensitive. The question that we're looking at, John, is what are the right questions that nurses find acceptable? And we do have a project that's funded by Robert Johnson that we're going to be doing that with nurses to see what's acceptable. That's number one. The other issue then is that how sensitive and specific are these screens? And that's a challenge. In March, George Fischette will be coming here if we get a chance. I'll make sure you meet with him and come to Grand Rounds. He's a real maven on this stuff. And the thing is that the sensitivity, the ability to detect truly the need for, or truly the lack thereof for, with the screening tools that are available now, is equivocal. So then we say, okay, if that's the case, I still think we have to figure out a screen. We have to educate the nurses to feel comfortable doing it. Then you have to figure out from which part should it go. Where in the course of treatment? To your point, I do think there's certain nodes or triggers in the course of management of a patient that we definitely have to be very sensitive to that should be a trigger. And I definitely think order sets is one way to go. For example, there's something called the respiratory failure pathway. Maggie and Von Scharnbaum working on with Umesh Gajwani in the CCU. Should there be hardwired chaplain seeing somebody when they're hour 96, I think, for the respiratory failure pathway? Should a chaplain come at that point? It's such a difficult time to decide, because when somebody's on a ventilator that long, for those who don't know, their prognosis for getting off of the ventilator is much less than if they're on the ventilator 72 hours or less. Am I correct about that? Okay. So I would like to take this research and say we have work to do at Mount Sinai with what we already have now in terms of technology. One is EPIC, the other one is MION, because what I thought was very interesting is that medical students use MION. And to your point about teaching medical students, that's something we are working on actually with Ed Poliandro and David Muller. And then the question is, if indeed it is going to be through MION, we have to teach the medical students to know how to ask the right questions, to know to click on MION, and then we can quantify. So I think nurses are going to be more likely to use EPIC, it seems, and MION. Medical students with MION social workers, we don't know what they're going to use yet, but this being built out of what you found is a very important first step, and it's our responsibility as a department to socialize it so that we can quantify it. So John, from a medical student perspective, what do you think would be the next steps that you would like to see?
Yeah, so I guess personally, during my first 2 years of medical school, the only mention of any type of spiritual care, which I found very interesting because for me, this is such an important part of my life, and so, and also like, I think a lot of patients who are going through such a difficult time during different diseases and things like that, I thought that spirituality would be kind of more emphasized in the curriculum. But when I did come here, I think the only time that it was mentioned, at least from what I remember, was it was a bullet point on one slide of the social history, and the presenter didn't actually even mention it. It was just on the side. And so that's kind of the extent in which at least my year has gotten any type of training, formal training, at least in spiritual, how to spiritually counsel patients or get referrals for patients, or even what the idea of a chaplain is. I don't think that was even ever brought up during any of our lectures. And so for me, I had heard that there were kind of initiatives coming up to try to incorporate more of this into the art and science and medicine curriculum, which is the curriculum for medical students, where we learn how to do history taking, how to do physical exams, how to think about different biases, and how to kind of like basically how to be a good doctor class. But that there are certain initiatives to try to incorporate a little bit more on how to address spiritual issues with patients in the art and science and medicine class. So for me, I think that would be like one of the most important places, because to at least place the idea in medical students' minds that even if spirituality is not important for you, which it might not be for many students, the fact is that just like anything else like we ask, just like any other question that we ask, even if some of those questions aren't important to you, that's not so important. The important thing is that it might be important to the patient. And that's what's always emphasized in our classes, is that what's important to you might not be the same as what's important to the patient, and it's important to address what's important for the patient. And so I think that spirituality and addressing spiritual needs for patients should be framed in that way in the medical school curriculum as well. So I think that's like an important first step. And then secondly, like Dr. Marin mentioned, I think the great thing about being a third-year medical student is that like the interns, the residents, the attendings are like so busy, especially on the floors. They just like have so many patients, so many things to do, and like the nurses too. Like I just don't even know how they do all the work in one day. And the great thing about being a medical student though is that you have a lot of time, and the purpose of being a medical student is to spend a lot of time with the few patients that they give you. Usually it's only like 2 to 3, but at least there are multiple medical students, so you end up covering a lot more patients. And usually they tend to give you kind of the sicker patients, because you're also learning from the patients as well as hopefully giving something back to them as well. And so I think that this is like a great place for medical students to be able to make an impact, especially because oftentimes as a medical student you feel like you feel sometimes ambivalent about whether you're actually making an impact in the patient's life, and when the places that you do feel like you're making an impact are where not necessarily, sometimes it's medically related, you know, if an intern happens to have forgotten a certain diagnosis to think of, or whether a certain test was ordered and wasn't followed up on, or, you know, the small details that are sometimes missed as a medical student because they have so much more time to follow up on those. I think those are definitely areas where I feel like I've had an impact on the patient's care, but for the majority, I think, is where I feel like I've had an impact is the amount of time I could sit down with a patient and really learn about them, and then bring that to the providers and be like, look, this is what this patient really wants, or this is what this patient has as their goals of care, or this is what this patient wants in their hospital visit. And to be able to request chaplains and have medical students do that, I think could be one place where it would be mutually beneficial, where patients would get the benefit of having their spiritual needs met, but also medical students feeling like they are contributing even more to kind of the patient's care in that area. So I think that's a great
point. Toward that end, I think that is something that should be pursued, but if that happens, I think it would have to be done in concert with the residency directors and perhaps the teaching attendings. And let's just take medicine, since medicine is such a large footprint. You know, at Mount Sinai, it seems that we would have to be very careful when developing curriculum. What I don't want to have happen, I could be back to the morale of a medical student, and perhaps the coordination care of the patient. So the medical student says, let's bring in somebody, and the resident doesn't quite get it, or, although I think the hospitals here are one of the most psychologically minded doctors actually at Mount Sinai, we will have to figure a process improvement plan to put that into effect. And it seems to me that both medicine and psychiatry would be the two areas, because they're cognitive specialists, and the length of stay is a little bit longer. I'm just thinking out loud here, and I think that's something we definitely need to explore. I do know that when Raphael and I spoke to medical students, when you arranged it, there must have been like 60 people in the room. So clearly there's an interest in this, and we have to figure out the next steps. I do think the next steps will be actually with the medical students working with their ASM preceptors and getting them on board, at least at that platform, and then we can work up from there as they move into the clinical year. That's just an hypothesis I have. Any other ideas on this? Yes?
I'm just thinking, we're talking a lot about technology, not to forget the human component. And I know some people are taking chaplain interns and medical students and introducing them. And I had the experience yesterday on the floor. I followed a nurse de-escalating a patient. The next day, I got 3 referrals from that nurse, and she knew my face.
Absolutely right. Absolutely right. I think that's it. To me, technology is a facilitator for improved patient care because we live in that kind of world right now. And I think what Healthcare Chaplains Network has done, while we don't have the proof that it works, I do think the idea, getting back to outpatient, is that these patients who we see here, lots of them are outpatients at Mount Sinai before they became inpatients. We know that. They're in the system. We have 7 hospitals. You could argue that technology can be used to get to the outpatient, to hook them up with Mount Sinai in some way that's patient-centered. But what you're talking about, which I think we have to think of a way to do that, like into-home hospitalization with remote monitoring. But there's no question, teaming up, there is a small but important literature that shows that's the way to go. That's one place where David Fleet and I have talked about actually where do chaplain interns, are there CP interns here in the room? Some very senior interns in the room. Here the issue is where do interns play in that welcoming and shadowing with people? Maybe that's an opportunity because we have not many chaplains here, but we do have a fair number of interns here at a given point in time. And that may be an opportunity too. But I think medical students being connected with chaplains, which is how to do it, is an excellent idea. Okay, it's 10 o'clock. Please, can we stay here a little bit longer?
Yeah, we have until 10:30.
Until 10:30, great. Please.
There's just one response to your research. This is wonderful. But as a chaplain also, I daily struggle with the language of spiritual care. And one question chaplains often ask the patient is, what do you mean? Or tell me more. And the same question I have is, for instance, in the research, 41% of the patients, they wanted to discuss spirituality and religion. And that's so abstract because it's not daily language. Like, what do you mean you want to discuss spirituality and religion? Because one response sometimes I get from the patient is, I don't have time for spirituality and religion. I'm just overwhelmed with what's going on with my body and with my family. So there's some people, or many people maybe, have an image of spirituality and religion, sometimes important, but right now I don't have time for that because there is some separation in the image. So maybe in the research, if there is a breakdown of like another question, like, okay, you say you wanted to discuss spirituality and religion. What do you mean by that? Like, what do you want to discuss? Discuss what? Spirituality, or it's not talking about spirituality, but about your situation, but then in a different way, using spirituality. What's happening there? So maybe like breakdown of what the person wanted to discuss more in detail, concrete. And also the private providers, what makes it uncomfortable to make a referral of chaplains? And again, the social workers or those people who, it's difficult to make. What do you mean? what's happening? What makes you so uncomfortable? And then there is a story, and maybe in the research, perhaps that becomes more clear. Like, oh, I'm afraid of bringing religion to this situation. This is a very clinically acute situation, or I don't want anybody proselytize my patient, or whatever story is there. So that'll be more, yeah, I'm interested in that one too, like a breakdown.
I think that John, based upon this literature, can answer some of the questions from the barriers. If you want to elaborate.
Yeah, so I guess just briefly talking about a couple things that you mentioned. One of the things that I've been discussing with Dr. Marin when we first came up with the project as well is the idea that there are a lot of things that aren't necessarily standardized in the field of addressing patients' spiritual needs, and that there's a lot of places for improvement in terms of standardizing, even as Dr. Marin mentioned, like screening processes for patients, but also what exactly, when a chaplain visits a patient, like what exactly are the standardized things that they can kind of say that they did with a patient as well. And so I think that there are a lot of places for becoming more standardized, including what patients exactly mean when they speak about religion and spirituality. So I think that's a great point. In terms of like why providers might not be referring and things like that, it seems, at least from the surveys, that providers feel relatively comfortable with the idea of referring to chaplains, and they don't see that as something that's necessarily proselytizing or imposing their views. I personally think the issue has more to do with the fact that spiritual care is not yet seen in most of medicine as an integral part of healthcare. So for example, in palliative care, because chaplaincy is seen as an integral part of the team, the referrals are much more frequent and seen as almost necessary, right? So I have a particular interest in palliative care, and I would like to go into that field in the future. And so I find it interesting that, at least in palliative care, the chaplain is seen as an integral part of the care, is present during family meetings or when you're first introducing a patient to the team. And so in that way, like, the chaplain is almost always brought into the picture. Then, you know, if the patient's not interested, then the chaplain doesn't see that patient, but at least it's there from the beginning. And you see in the literature as well that this is true not only in palliative care, but in certain fields like oncology, where like spiritual care is seen as much more important, and that there are more referrals in that field because providers see that spirituality, addressing patients' spiritual needs, is a part of the healthcare, of the patient's care. And so I feel that it more has to do with this perception that in other fields, perhaps this is not really seen as the case, that chaplaincy and spiritual care isn't necessarily a necessary part of the patient's care.
Yeah, I think it gets back to the order set concept in that what's best practice. So historically, PAL care and cancer care were end-of-life care historically. PAL care now is not end-of-life, and cancer care is not end-of-life. Cancer is a very treatable illness, so extending hardwiring chaplains into other illnesses with and without order sets being involved is the way to go. For example, congestive heart failure. People with congestive heart failure, and Dr. Nguyen can speak to it, have a much more likelihood of dying in 5 years, as far as I understand, than a person with cancer does at this point. With their life trajectory, is that when you get to a certain stage or class, correct in CHF, you're going to die. There's a high % death rate. So perhaps we should look at incorporating chaplaincy into illnesses that we know make a person closer to death, actually, or difficulty in understanding why they're in pain and having trouble breathing, which hasn't, I think, been explored, which we're trying to explore here at Sinai, by the way, for those who don't know. But I do think it gets back to the order sets. So when somebody gets to a certain point, we know from the doctor's experience here, and Vin, you can speak to it, we know that if the order sets aren't done correctly, you may forget to do something. And perhaps you can talk about that, and perhaps that's where a chaplain should be incorporating an order set, because we know from the literature there's certain times when they really should be giving an aspirin or something. Do you want to talk about how valid order sets are in medical care?
Sure. So, John briefly spoke about how busy the life of a resident, a physician, a hospitalist on the floor is. And they're typically very kind of overwhelmed with all the different tasks that have to go into the day just to take care of the patient. And a lot of it is medical, a lot of it is administrative. So in just regards to direct medical care for a complicated illness, what we found is that people can forget to put in integral parts of the workup or the treatment of the care. And the way that we've kind of taken the human error out of that and make sure that people remember is to put it into an automated order set like Dr. Marin was talking about. So that's kind of been one potential way that we've leveraged technology to make sure that we don't miss anything, to make sure we're addressing the totality of the patient care. So I do agree with you, and I think that is an area that you can make something, automated is not quite the right word, but bringing it more to the forefront of the provider's thoughts.
Thanks a lot. Yes, Nadine.
Speaking as a chaplain, I'd like to affirm that as a non-clinical person, look at the medical staff. What I see is there are trigger points for consults. There's a trigger point for a sepsis consult. There's a trigger point for a cardiology consult. If we could quantify in some way trigger points for spiritual care consults, I think that would be a big step in the right direction.
I totally agree with you, and Dr. Nguyen, if you're interested in working with me on this, we're working with the Heart Hospital anyway right now. I think we can definitely do that. I think it's an excellent idea.
The second thing that I find is that sometimes, and it's especially with nursing consults, it seems to me that when someone makes a cardiology consult or a pulmonary consult, they said to the patient, I'm going to have someone see you. Lots of times, I go to a patient on a nursing consult, and the patient is like, why are you here? It hasn't been communicated to the patient that I'm going to ask a chaplain to see you. That is something that I think would be helpful if we could bridge that gap.
Good ideas. I think that one more, yes, Sonia.
I say, in terms of nursing, there are many times that nurse feels that the patient needs someone to visit to support, not because the patient is requesting to have a spiritual person, but because the nurse feels that it's so important for to have the entire team visit. Okay, so if you get a referral, then stop to speak with the nurse first to see, okay, why did we make this referral? If the nurse who made the referral is not there, somebody else might be able to say, okay, the patient did not request it, but we just wanted someone to visit. And so if it's not, oh, I'm coming to see you because the nurse asked me to, there's still a difference. So if it's just, I'm coming to visit as part of the hospital team, I'm just coming in to say hi, to see how you are, and if there's anything I can do to support you. Then that's a little different from the patient requesting it specifically, and then you said, I'm here because I understand your request to see the chaplain. So that's...
You're spot on. I think there's two ends to it. There's the nursing end, but I've asked Raphael and David actually to script what the residents and interns are going to say, because I think our chaplains here are pretty good at knowing what to do, but in general, if you don't always come to say the right thing, you're not always going to say it. But this is part of we're part of the healthcare team, we're part of, and managing up, this is an old term we still use, the nurses and the doctors. I think that will make the patient feel that they understand what's going on, because they won't understand otherwise. I totally agree with you, Sonia. One last question, comment? Yes.
I was going to say that on the education piece, at the spiritual care department at Mount Sinai, we did an educational session for the residents as part of one of their weekly, they do weekly meetings and lunches on Fridays. And we found that that was very helpful. There was a lot of interest, and in fact, we had an uptick in the number of referrals in the weeks following that. So
I think that's
something we could institutionalize and make a regular part of the curriculum. I think that would be helpful.
What do you think, Ben? I think it's feasible?
Yeah, I think it's a really important thing. I think like the education aspect is such a key part, to have people both value it and also to have people know that it's there.
And also, I think closing the loop back, because we know that the nurses and doctors are not going to be the chaplain noise. So one of the issues that Raphael has spoken about, and I don't think we have done this as well as we necessarily could, or we can look at opportunities for making it better, is chaplains have to get back and thank the person who ordered and go, we did this, thank you so much, because unless you have that loop, which is not technology, I think we're not giving them the attribute that they need to know that it was important that it did that and why. Okay, and we have to make sure we do it in a way that's systematic, that's all I'm bringing up. That's what's important. John, outstanding. Really, thanks again.
Thank you again, John. Thank you, Dr. Aaron. Before you leave, I have 3 quick announcements. Just a reminder to please complete your evaluation form and leave that on the table right outside.